I mean, I do like a burger.
I am with you, Randall.
I'm not going to lie.
I love a burger with a milkshake. And we're saying that.
I'm thinking Dubai chocolate and Dubai burger. Welcome, Dr. Donald Fick.
Thank you for having me, Randall.
GP in Maldene, but you've also done lots of other things. You've been on television.
Yeah.
You've worked behind the scenes on television
Maybe
in a medical capacity.
Yeah.
But you've also worked alongside a plastic surgeon and a general surgeon.
Yeah.
But today we're going to talk about obesity and the fact that obesity isn't simply about I eat less, I do some running or Tai Chi, and then I'll get thinner.
Yeah.
But in fact, it's a disease and it needs to be treated. And in fact, in America, 30% of Americans are obese. That's 100 million people.
Yeah.
And the numbers in South Africa aren't...
They're not far behind, right?
Exactly. So how is this a disease?
So we've got to reframe the way we think about obesity. And you're quite correct. Back in the day, I remember being at medical school. It was all about move more, eat less, and then you'll be thin. But now we're reframing that and thinking obesity is a chronic disease and eating more doesn't make you obese. Obesity makes you eat more. So we flip that on its head.
But my question is, well, firstly, as a species, we didn't have abundance. So we were hunter-gatherers, for example, and you killed a sheep, and the sheep had to last as long as it did, and then you technically fasted for long periods of time until you found another sheep. Now, with respect, there's a fast food joint on every corner.
Even worse than that.
And they can deliver it.
It's on your phone. And I think we are seeing that more and more. We've become more sedentary, and things are far too convenient. And marketing, media, social media all play into this. And over time, human behavior changes, and obviously that works on certain parts of your brain where behavior changes, and therefore the desire to eat more becomes more and more. And we're the only, talking about species, we're the only species on Earth that eat for pleasure. We love that dopamine hit. And I think in 2025...
Also, 3 meals a day is really...
It's too much, right?
Well, also, it only, 150 years old.
But I also want to know who came up with that 3 meals a day, and was probably... a fast food. It was probably someone in the food industry that came up with that. It's like interesting facts. Like there's no scientific evidence to say you need to walk 10,000 steps a day. A pedometer company used it as a marketing hack, and now we've done that ever since. So maybe I don't know anything about this. Maybe those 3 meals a day didn't come from science. It came from...
No, it didn't come from science.
In
fact, it was in European society, and again, it was a situation of abundance.
Yes.
It was literally for wealthy people, because poorer people couldn't afford 3 meals a day. I want to ask though, so I'm feeling hungry. What does that mean?
So that works on many pathways. So obviously, and we're going to touch on this a little bit later when it comes to GLP-1 receptors. It's a thought in your brain. So centrally, you now start thinking about food. It engages enzymes in your gut to start thinking, yes, you start salivating. The desire for food becomes more and more. And I think...
And there's a good chance that you see food.
Yes.
Because you're exposed to it.
And this is why we think obesity has a huge psychological component as well. And as I mentioned earlier, there's a lot of us on our phones, myself included, all the time. And what are some of those ads that we see on social media is food. So it prompts a thought in your head. Yes, those GLP receptors in your head then get activated and you're like, I need to start eating. And then some people can. I speak for myself, I can't. When that food noise kicks in and it starts controlling your mind, you can't stop thinking about it. And that's I think what happens. But I also want to come back to some of the stats that you said, that 100 million people in America are obese?
Yeah.
I think what we don't know in South Africa is that 27% of adolescents are obese. So we're starting young. And I think a lot of it has to do with lifestyle. Children are more on their screens. They don't exercise as much as maybe they did when we were younger. Parents are busier, so they're more inclined to buy the kids fast food.
They don't want the kid to go and play out on the road.
No, exactly. It's a safety issue in South Africa. But also parents are busy, so they're not making sandwiches or making lunch for the kids to go to school. Drive past McDonald's on the way on a Tuesday morning at 7 o'clock. You'll see the queue with moms and kids there. So that's a bit of a problem. 47% of women in South Africa are obese and only 24% of men. So it's a condition that affects more women, which is strange because usually men always carry the health burden more in this country.
Absolutely.
But it is definitely a female thing. And I think in South Africa, these obesity numbers also speak a lot to culture, whereas it's better to look fuller. That's a sign of prosperity. It's a sign of abundance. Whereas if you're thin, you're deemed as poor.
Well, or supermodel.
Yeah.
Let's talk about GLP-1 receptor antagonists
Yes.
and semaglutide. Are they going to become, in the next 5 to 10 years, is everybody going to know them like they know AI?
Yes, I think so. I think it's the biggest thing in medicine at the moment. I think I've been in private practice for 15 years. I've seen certain drugs excite medicine. I think Viagra, when it came out.
The blue tablet, obviously.
Yeah, the blue tablet.
Excitement.
To cure erectile dysfunction. Then we saw big changes in the HIV space, and I think this is the next one. I think it's bigger, it's more culturally topical than boob jobs, fillers, or Botox, because everyone wants to be thinner, right? Like you speak to anyone.
So that's a very interesting point, and I did think about it. On the one hand, you've got an enmeshed, growing desire for food and abundance. And on the other hand, you've got the world telling you that you should be ripped and fit and be able to run and jump and go to gym.
Yeah, and anything more than a size 28 is not acceptable.
How do you balance those messages?
We don't. And that's why humans are struggling, right? Because so much abundance of food, yet the messaging is changing. And I think we want to also debunk some of that messaging today, that everyone wants to be thin. And I think this speaks to who gets these drugs and who doesn't get these drugs as well. Because
it's not necessarily that everyone wants to be thinner. But the fashion industry, for example, is not based on people who are obese.
Yes.
Right. Those are not the messages.
It's changing a little now. Like you look at some of the narrative and it is different.
There's a little bit of change. You know, it's almost like we feel bad about what we told you in the 70s and 80s. Yeah. But it hasn't changed that dramatically.
No.
So, tell me about semaglutide, the active ingredient in what was originally a diabetes drug.
Yes. But it's some people call it a weight loss drug. I'd like to, in a medical sense, see it as a disease-modifying drug. Based on what you said earlier, obesity is now seen as a chronic disease. And like any other chronic disease, whether that's high blood pressure, hypertension, high cholesterol, as doctors, we've always told people that you need two components to manage a chronic disease. You need lifestyle modifications and you need medication.
Yep.
We've preached lifestyle modifications for a very long time when it comes to weight loss.
We must just say, firstly, to the audience, if you're going to listen to us and discover Wegovy and Mounjaro and Rybelsus, please firstly consult a medical professional.
No, definitely. And I think I want to touch on this, and I feel like I'm jumping a little bit all over the place, but please consult a medical practitioner. And there are websites, I think it's thinkaboutyourweight.co.za, that has very good information there. They'll tell you who prescribes it, where to get these things. Sadly, with some of these drugs, there's a lot of counterfeiting at the moment. You can get them from beauty parlors, you can get them at compounding pharmacies. That is illegal, and I think we should just touch on that as well.
Yeah, in the US, there's been a massive growth at compounding pharmacies.
Yeah, because these drugs are not cheap in a South African context.
What are some of the costs? I read $1,200 a month in the US.
On average, I'd say between 2,500 to 4,000 rand a month per person on these drugs.
And it's an injection.
It's an injection. And then some compounding pharmacies have gone and said, we'll do it for you at 1,000, right? But we don't know what active agents are in there. We don't know what ingredients they use. We don't know if it's safe.
And that's what it certainly wouldn't have gone through all the necessary regulatory.
No, definitely not. So I would be scared injecting something into my body that I don't know. But so many people do it. I think there's been a huge outcry from the medical industry. And I think Canada's passed laws against this recently. But compounding,
the US are about to do so.
Compounding pharmacies that make these medications. So please consult a doctor. If you are thinking about these drugs, they're not for everyone. I think there's population groups and certain patients that benefit from these things, but it's not a one-size-fits-all. And I think every individual basis is dealt differently.
Give me a medical definition of obesity.
A BMI above 30. That's per definition what it is. And if you look at so many South Africans, we're above that already. Why obesity is...
But there are going to be people who are unhappy with their weight.
Yes.
Who may not check their BMI and still want to take Wegovy.
And that's why it's so important for the prescribing physician to manage this appropriately. That, as I said, it's not for everyone. It's not for a supermodel that's already got a BMI of 23 that wants to look even thinner for the summer holiday. It's not for that type of patient because it's not a weight loss drug. It's a disease modifying drug. And we want to, it's the outcomes we want to prevent.
It's the first drug that kind of the average weight loss is 15 to 20%.
Yes.
But I guess when you're 160 pounds,
so that's
losing 20% is a good thing.
It's a very good thing. So I think studies have shown that, back to our previous point of lifestyle modification, if you only have strict lifestyle modification, only 10% of patients will lose 5% of their body weight. So with lifestyle modification and these injectable drugs, you lose about 5 to 15%. If you want anything, and some people do up to 20%, if you want to achieve anything more than that, then bariatric surgery is the next option. We only start seeing like the good medical effects after about 5% in body weight loss. That's when you start seeing a drop in blood pressure. That's when you start seeing remission of type 2 diabetes. That's when you see people that aren't diabetic reducing their risk of pre-diabetes. And for me, as
heart
a
disease
doctor, and I was about to touch on that, heart disease is the most important thing. Semaglutide 2.4, which has just been launched in South Africa, is shown to reduce MACE, which is a major adverse cardiac event, which is either a fatal or non-fatal stroke or heart attack, by 20%. That's why we call these drugs disease-modifying drugs. They reduce your risk of a heart attack or a stroke, which is so important.
But significantly, if you stop taking the drugs, you're going to go backwards.
Yes.
So this is if you're on the obese side of the scale, this is the rest of your life.
Yes.
Along with the exercise and
I can't stress that enough, but so is every chronic disease, right? I often joke, and I say this lightly, like medicine doesn't cure many things, but it manages a lot of things. And I think like high blood pressure, like asthma, like HIV, we want to have people that now have well-controlled obesity is what we're looking for as a goal.
What does
like you have well-controlled
cholesterol?
Big drop in lipids. Cardiometabolic risk reduces, so it will drop your blood pressure. Let me say this, not the drugs, but losing the weight and modifying the disease will drop your blood pressure, drop your cholesterol, drop your sugars, improve your renal function, improve your mobility. It's got so many positive effects on the obese patient.
I've been reading a lot about how these drugs may affect societal perceptions about obesity. But, you know, look, let's just be honest. If you grew up in the 80s, someone would say, you're fat. Stop eating. You know what I mean? There are fat people and there are normal people. So you were an outcast, like an outsider.
And we speak to the mental health aspect of this as well. The social isolation, the anguish and the agony. And these people have tried everything. I think I see in GP practice so many patients that have tried every crash diet, every exercise plan, every app, everything they've seen on TV. And eventually they realize that they're only going to lose that 5% and they lose motivation. They lose morale. And then the depression and the anxiety kicks in. And as a coping mechanism, they eat more. So this is such a vicious cycle.
What does it do for the diet industry, though? For the magazines and the websites that are always like, try this new diet and that new diet. And
what is the language policy on this show? It probably pisses them off, right? I think that's what happens.
The fact is, with respect, I have friends and I don't see them very often. I see most of my friends often, but these are specific friends I don't see often. And they're always discussing have you been on this diet?
Yes.
You've been on that diet. But I mean, isn't it really basic? You reduce carbs, you reduce sugar, and you should lose weight. And a lot of the medical changes will also come with that.
But as we said earlier, that's what we thought. And I think in 2025, we're starting to think differently a little bit about this. So many studies have been done. So much research is showing that it's not just that when it comes to obesity, there needs to be an additional intervention. And the problems with these crash diets are you need something, when treating a chronic disease, you need something that's sustainable and that you can do for a very long time. You can't do banting for 10 years. You can't run, some will argue this, my wife included, you can't run 50 to 100 kilometers every week for 10 years. So we need a long-term fix because these crash diets don't work.
And we also said earlier that you are surrounded by messaging all the time about...
The noise is intense.
I mean, I do like a burger.
I am with you, Randall.
I'm not going to lie.
I love a burger with a milkshake. And we're saying that...
I'm thinking Dubai chocolate and Dubai burger. They're both on my mind.
And we're saying this is why managing this chronic disease is so important, because we don't want people to starve themselves, deny themselves these things. I always say, like, when it comes to these things, like, don't go cold turkey. Don't go, be consistent. All or nothing is the thief of consistency. So you want something where you can enjoy a burger on a Friday night. When you're watching the rugby with your friends, boerewors roll, all the sauces, have a beer. But it's a chronic disease that needs lifelong management. And I think crash diets and these fitness programs preach against that. They're like, every day, all in, never look at a chocolate bar. That's impossible, right? For me, at least.